All right, just let me know if for some reason you can't hear me or whatever, because this is new to me. All right, so I'm Lindsay. I am one of the dietitians here at Mary Bird Perkins Cancer Center. I also work with Fidel Shivers. She kind of focuses on radiation, and I'm in the chemo world, so I work mostly with the chemotherapy and surgery patients. Been here about 7 years now. Went to LSU, graduated, did my internship through UL Lafayette. Seems like so long ago, but yeah. Anyway, so we're gonna get going. I guess if y'all got questions, just let me know. I guess you can do that at the end of something like this.
They could just put it in the box and then I'll just ask you at the end.
Okay, perfect. All right. So of course, objectives, at the end of the presentation, you should be able to list at least 3 different types of common cancer treatments, discuss the importance of your carbs, your fat, and your protein needs for cancer patients undergoing treatment, and then describe the latest recommendations for cancer prevention, which we'll cover that closer to the end. All right, so just some basic statistics about cancer. It's the second leading cause of death in the US. Close to 1/3 of all cancer deaths in the US can be linked to diet alone. Your intake and nutritional status can alter the risk of acquiring cancer, the type of cancer, and the age at which it may appear. So together, diet and exercise are powerful forces that can reduce excess weight, which goes hand in hand with a cancer risk factor. Whoops. All right, so just the definition real quick. Basically, what is cancer? It's the out of control growth and accumulation of abnormal cells that starts from damage to one or more genes, which when I started working here, I had no idea that we all have cancer cells in us. It's just when they become active is when it becomes treatment and everything else. So you got malignant, which is invasion of the surrounding tissues. And then your benign tumors are abnormal growth, no spread. So that's not considered cancer. So we pretty much treat the malignant cancer here. All right, and I'm just going through these quick because I want to get to the good stuff. But so this is updated since 2020, estimated new cancer cases in the US. You can see for men, prostate is the most common at 21%, going to lung and goes down from there. And women, breast cancer is the most common, which we used to see a lot of breast cancer here. That was probably my biggest population until Women's actually opened up their facility. So now they have a lot of the breast, but you'll see again in men and women, lung is pretty much second. And I see a lot of pancreas. You'll see it's a very small percentage, but numbers are kind of increasing with pancreas. We're catching more and more earlier on, which is also always a good thing. So just a heads up on that. Now we got the cancer deaths. You'll see for both men and women, lung and bronchus are the top ones. And then men, you got your prostate. And then women, it's breast. Okay. You'll see pancreas closer up to the top here. It is one of those very low incident rate, but a very low amount of people get it, but it is a very rough, aggressive cancer. So, all right, this is just interesting. The lifetime probability of developing cancer for males. Prostate again, 1 in 9. Your lung is 1 in 15. Colon and rectum is 1 in 23. And then goes from there. But I would say here at our cancer center, we see a lot of colon, a lot of lung. We actually do have a good bit of pancreas, esophagus, gastric. Those are our big ones. And then in women, lifetime probability of developing cancer for females, you got breast is 1 in 8, lung 1 in 17, colon and rectum is 1 in 25, goes down from there. All right, so now I'm going to get into the stuff that I like to talk about. So we're going to talk about how it's staged. That's a big question a lot of people have. How do they determine if it's stage 1, 2, 3, 4? What system do they use? So this is where we'll kind of talk about that. So it's going to be based on the size or extent of the primary tumor. And then, of course, if it's spread to nearby lymph nodes or other areas of the body. So if the cancer cells have penetrated beyond the original layer of tissue, the cancer has become invasive and it's categorized as local, regional, or distant based on the extent of spread. This is all kind of, I don't expect y'all to understand this right away. It's very confusing. But they use this T&M system, which makes it a little bit easier to understand. And this is all for staging the cancer. The T is going to stands for the size and extent of the primary tumor. The N is the number of nearby lymph nodes that have cancer. And then the M is whether the cancer has metastasized. So usually you'll probably be more familiar with stages 1, 2, 3, and 4. Of course, the higher the number, the larger the cancer tumor, and the more it's spread in the nearby tissues. Usually with stage 4, it means that it's spread to distant parts of the body. So like a stage 4 pancreatic would be, let's say it's local region is in the pancreas, but it's spread to liver. So that's an automatic stage 4 pancreatic with mets to the liver. So that's just kind of a primary example. All right, so the types of cancer treatment. So like I said, I specialize with the surgery. And when I say surgery, Whipple, like your pancreas, gastric, esophagus, and then as well as the chemotherapy. Vidal Shivers, who's down in radiation, she does a lot of the basic radiation, sees a lot of the head and neck cancers. That's kind of her area of expertise. And then we'll get into the chemotherapy, the biologic therapies, and the hormone therapies. It's actually very interesting information. So we'll get into all that here in a second. All right, so the nutritional effects of cancer treatment, surgery, to head and neck, it can impair taste and smell, impair your chewing and swallowing, and increase regurgitation. So some of these people may have surgery before they even start treatment. They may have surgery alone, but just that can cause a lot of those issues with the saliva glands. They're not producing enough saliva to break down food after the surgery. So a lot of nutritional complications come from that. Your esophageal reflux and aspiration are huge. We see that all the time, and we have to be careful. We assess our patients and say, okay, they're coughing after they're swallowing their food. That's a sign of aspiration. We need to get them into a speech therapist to make sure they don't choke, aspirate, and cause a lot of issues from there. And then, of course, esophageal also have restricted swallowing. And we've seen cases here where the mass is pretty much protruding the whole esophagus, so they can't get anything down. So until they start treatment or have surgery or whatever, it's a very big challenge to get them nutritionally to do what they need to do. And then your gastric, which is your stomach, of course, early satiety. They can only eat so much at one time. Like when I say so much, it's like maybe 4 ounces of liquid at a time, half a cup. It's very, very small amounts. So they have trouble getting in the calories they need, as well as dumping syndrome, which is basically just that rapid gastric emptying. If they have to resect part of the stomach to the intestines, if you eat too fast or eat too much, it can dump and cause all that gas, bloating. They could even vomit, nauseated. So it can cause a lot of issues there. And then, of course, we know stomach, intestines, we do a lot of our absorb a lot of our nutrients and vitamins and minerals. So we do see quite a bit of those vitamin and mineral deficiencies. So we kind of have to keep an eye on those lab values as well. Pancreas, which is kind of my specialty. It's called a Whipple surgery. So with the Whipple, if the patient's tumor is localized in the head of the pancreas, which you can see in the diagram, the head is the closest part to the duodenum. So with this surgery, they're going to remove the head of the pancreas, your first part of your small intestines, which is the duodenum, and then the gallbladder and bile duct. So these patients, they have a lot of issues right after with impaired digestion. They have the fat malabsorption. Diabetes is a common thing just because of the insulin. And then the enzyme deficiency, which I work a lot with getting our patients on pancreatic enzymes, because with this, your pancreas you basically need to replace the enzymes that your pancreas would normally make, which we all know the pancreas, the enzymes help us break down our carbs, fat, protein. So it's crucial if we notice patients having a lot of diarrhea, a lot of vomiting after these types of surgeries. Okay, maybe they need to be on an enzyme to help break their food down, which you would just take it with meals. And it does make a huge difference with the fat malabsorption and the breaking down of their food. All right, so another surgery we see a lot is the small bowel resection. Common issues with this are diarrhea. You got the malabsorption again, so you can see with a lot of these, absorption is affected, which is why we kind of lock down on ways to help them with their absorption of their food. And then again, vitamin and mineral deficiency. So you can see we work a lot with these GI issues, which of course, when all that's out of whack, it's very hard to keep your weight stable and you just feel terrible. So we got some nutritional effects of cancer treatment. So you got chemotherapy and radiation are two big treatments that we use here at Mary Perkins. So and you'll see some of them are similar, some of them are totally different kind of side effects, but with the chemotherapy, you can have a lot of nausea, vomiting, appetites can decrease, diarrhea. You can have a lot of the chemo drugs cause diarrhea and or constipation. So it gets tricky to kind of help them get on a bowel protocol to help with these side effects. Sore mouth or throat, a lot of the chemos can cause mouth sores. So we recommend using a salt baking soda rinse as a preventative measure to help prevent mouth sores. Change in taste of food and smell. Some of the drugs, if like example, oxaliplatin, cisplatin, a lot of your platin drugs can cause that metallic taste. So we have to recommend using plastic utensils, no metal utensils, not even drinking anything or eating soups out of cans. So we kind of have to adjust a lot of their eating patterns. White blood cell can drop, which is very common with these chemos, white or red. So I do a lot of educating on food safety, making sure they have to cook all their food well done, washing all their produce. I typically recommend a vinegar water solution. They have to be very, very careful. And then the red blood cells, of course, is just a side effect from the chemo as well. So it kind of gets their blood levels all off balance. So radiation is going to be more of your physical kind of side effects. If they're getting radiated to the head, neck, chest, or breast, you can get a lot of dry mouth, sore throat, difficulty swallowing, again, change in taste of food, dental problems we see a lot, and that increased thick mucus in the back of their throat, which when you have that going on, it's like a really bad sinus infection. You don't feel like eating. And then if they're getting radiated to the stomach or the pelvis area, of course, it's totally different side effects. You're going to have more of those GI issues, the nausea, vomiting, diarrhea, cramps, bloating. You can sometimes get the constipation. So it's more of the GI kind of issues. All right, chemotherapy. This is where it gets very confusing for students normally. So in this section, if you want to write a couple things down, because it will help you. Because when I started here, I didn't have any chemotherapy experience. I had to kind of teach myself all these different drugs. What is it doing? Because patients would ask me and I'm like, ooh, so I had to learn everything. But The chemo is going to be used for solid tumors and those at risk for systemic disease. So this is what I kind of focus in on the 6th floor here at the Cancer Center. So you have your hematological cancers, which are your lymphoma, your leukemias, a lot of your blood type of cancers. Adjuvant treatment to decrease the risk of reoccurrence after surgery. And I have in parentheses breast and colon, because that's two of the big ones that do this kind of treatment. So let's say colon, you had a resection, part of your colon removed where the cancer was. Basically, a lot of times they'll start them on chemo right after that just to prevent reoccurrence. They may have got all the cancer out, but they want just to make sure they got it on. There's no lingering cells or anything. So they'll do chemotherapy. So that's what the adjuvant treatment means. So neoadjuvant treatment means before surgery. Like breast and rectal, we see a lot with that. So the neoadjuvant, basically what that means is it's your first step to shrink a tumor before the main treatment. So example of this would be head and neck cancer. They have a mass that's pretty big in their neck. They can't just automatically do radiation because it's too big and the area would be too big to radiate. So they may start them on heavy dose chemo, do 2 rounds of that to shrink it. That way it's a smaller area that they would be radiating and not have to worry about damaging so much other cells. So that's just kind of a primary example that we see a lot. And then preparation for blood or marrow transplantation. We do a lot with those. Chemotherapy can also be combined with radiation. And normally when it's combined, it's a lower dose chemo. It just kind of helps the radiation work more effectively. So this would be head and neck cancer. It could be really any of the cancers, but it's just combined chemo with radiation. We even do chemotherapy just as like a palliative treatment. So if they have a form of cancer that's not curable, but we have a chemo regimen that can kind of help them live a little bit longer, give them an okay quality of life, not make them too sick, we'll start chemo just to kind of help try to expand their life a little bit and make it comfortable for them. And then we also use chemo preventative treatment to prevent cancer in high-risk individuals. So family member had all the way down the line colon cancer. Sometimes they do this heavy dose chemo just to prevent cancer just because you have that high risk. So we do actually see that as well. All right, so your classifications of chemo, again, this is probably going to be a little over your head at first, but once we kind of talk about it, it makes it a lot easier. So the cytotoxic chemotherapy, which is what you normally associate chemo with making you sick, it's all those toxic side effects. Basically, this form of chemo kills your good and your bad cells. So it can make you pretty sick. The Xeloda is an oral form of chemotherapy we use a lot with patients. Cisplatin is actually an IV chemo that we use. So those are just kind of some of those toxic chemo regimens. So there's that form. Then you have the hormonal, which is a form, these are all forms of chemotherapy. It's just kind of different subcategories, I guess you could say. The hormonal, you'll see right there, the example, Arimidex. We use a lot of that for breast cancer. So example of this would be that the Arimidex, what it does is it stops the hormone estrogen from encouraging cancer cells to grow and spread. So some of these breast cancers are sensitive to estrogen. So after, let's say after maybe they've done chemo or they don't have to do chemo, they just need to be on this hormonal type therapy. They'll take it, it's a pill, and it just basically stops estrogen from forming in your body, which is known to cause this type of cancer. So it's kind of confusing. That's pretty much the easiest example for hormonal. And then your biotherapies is something that's kind of newer. You'll see if you've seen the commercials for Opdivo, Keytruda, some of these that basically what they do is they rev up your immune system to fight off the cancer. So it's not putting all these toxic chemicals in your body. A lot of people do really, really well with the immunotherapy because it's basically just revving up your immune system so you don't get all those toxic side effects that make you sick, which we're seeing a lot more with the immunotherapies, which is great because hopefully the future of chemotherapy is immunotherapy because patients just do so well with it. And then you have your molecularly targeted therapies. And these are just basically, these are substances that kill the cancer cells by targeting key molecules in the cancer cell growth. So these kind of are more of a targeted therapy. They target just on those cancer cells, which we use a lot of that as well. They don't tend to make you as sick because it's not targeting the good and the bad cells. It's when you're targeting those good and bad cells like the cytotoxic, that's when a lot of patients have those side effects that can just make them extremely sick. All right, radiation therapy, I'm going to go through briefly because that's not my area of expertise, but we're going to cover it. So radiation can be used for local treatment to solid tumors. You can use it before surgery to shrink tissue, which is kind of what I was saying earlier with the head and neck example. A lot of times after surgery, they use it just to prevent recurrence. And then we do actually see quite a bit patients who have cancer and it metastasized, let's say to the bone or somewhere in the spine, who have a lot of pain. They can treat this pain with radiation alone, just to help minimize that pain and give the patient a better quality of life. And then also treat areas known to develop mets from primary cancer. So example of this is a lung cancer patient who studies have shown that, I want to say, I don't remember the exact percentage, 50% can develop brain mets. So the patients have an opportunity right off the bat when they start treatment for lung, if they kind of want to do this proactive radiation to the brain, just to prevent from getting brain cancer later down the road. There's side effects. You have short-term memory loss. So it's patients kind of got to weigh options. Do I want to chance it? Do I not want to chance it? But that's kind of a prime example of that last bullet point. All right, types of radiation, I'm going to go through quick because I'm not the best at explaining this type of stuff. But you got your external beam radiation therapy, which is what we use most of when you think of radiation therapy for cancer. That's that external beam radiating directly on the cancer from outside. So nothing's inside the body, it's all external. You have your internal radiation. And what this does is it uses a radiation source that's usually sealed in a small holder called an implant. And what they do is they insert this implant close to or even inside the tumor so that it harms as few normal cells as possible. And what this allows is a higher dose of radiation in a smaller area than might be possible with external radiation treatment. So just depending on the specific cancer, whether they need to get internal or external is okay. And then the stereotactic radiosurgery, I'm not too familiar with. I don't know if we do it too much here, but it treats an abnormal area. This minimizes damage to nearby healthy tissue. And this type of radiation is going to be more likely recommended for people who are too high risk for conventional surgery, whether it be due to age or other health problems. And in my understanding, what they do with this is it's a robotic arm that's controlled by a computer. It moves around you, focuses the radiation exactly on the area being treated. And actually, like the doctors and the nurses are in another room and they can see you on cameras and hear you and talk with you on microphones. It's very interesting. We don't really use it much here. We kind of stick with the external and internal. But those are the big 3 different forms of radiation therapy for cancer. All right, so now that was kind of the science part of it, which can kind of be to take in, confusing. Yeah, I know. But now more with cancer and malnutrition, the nutrition part of it. So the contributors, you got your tumor type. Like I was saying, a lot of head and neck, GI cancers, those alone, they come in already having a lot of issues, malnutrition. Of course, stage of disease, if it's further down the line, if it's a stage 3, stage 4, they may already lost 20, 30 pounds just because of the cancer so far widespread. Your increase when you have cancer, and this is what I explain to all my new patients. They're like, I've just been losing so much weight, which is pretty much the sign of why I got tested or to see if I had cancer. Because when you have cancer, you basically have to take in twice as many calories just to maintain your weight, because it's a constant battle between your metabolism. The cancer cells want the food, the nutrition that you're putting in your body. So it's constantly fighting and it makes you, of course, and that return lose a lot of weight. Adequacy of nutrient intake, abnormal nutrient metabolism, which is where a lot of times, like we were saying, the GI, the stomach, intestines, pancreas, when those are all affected, of course, what we absorb and what we metabolize is all can be out of whack as well. Type of treatment, of course, and then there's several other factors. Those are just some of the main ones. So how does it impact you? So how does this cancer impact you and cause this malnutrition? Delayed wound healing, weight loss, muscle weakness. We actually, with cancer, your protein levels tend to be a little bit lower. So these patients who have lost a lot of weight before even starting treatment, most of it is lean muscle mass. A lot of them come in and you can just tell it's a lot of the lean muscle mass that was lost, not so much fat, just that lean muscle mass, which therefore causes a lot of that muscle weakness. Reduced organ function, impaired immune function, morbidity and mortality, increased hospital stay. We see a lot of patients, which our goal is to prevent them to having to go to the ER for fluids, IV fluids, because if they're nauseated, vomiting, diarrhea, a lot of time need extra fluids because they can't keep anything in, which we try to prevent that, being the dietitians. Decreased quality of life, you got increased cost, and then decreased tolerance or effectiveness of treatment. So biggest thing being a dietitian in a cancer center, we want to make sure they're getting the nutrition they need. They're keeping their weight up, because I mean, I've had some pancreatic patients who started treatment. I mean, they had lost a good bit of weight initially, but lost more weight during treatment because of all the side effects. Couldn't even finish their treatment. So what's the only option after that? There's nothing else. So unless we try to get them built back up, but a lot of times when they get that far down, that's it. So we really, really, really try to help them keep their weight up, their nutrition up, just so they can get through the treatment and get rid of this cancer. All right, we kind of talked about this. Why is nutrition care important during your treatment? Address nutrient deficiencies, protect that lean body muscle mass, improve tolerance to treatment, your side effect management, maintain energy and strength, improve your immune function and decrease the risk of infection. Of course, we want to try to enhance the quality of life and increase chances of survival. So ultimately, yeah, we want to get them through this treatment the best way possible so that they can survive and continue on with their life. So being a dietitian with cancer is a huge, huge responsibility and a huge role. So what does the oncology dietitian do on a day-to-day basis? So we give recommendations to maximize the patient's nutritional status before, during, and after cancer treatment. So honestly, it's a long journey. The cancer journey is long. You start with pathology to determine if it is cancer, if it's not cancer. So at that time, they're already probably following one of my doctors. So I may need to see them initially before they even start treatment, because they may need to gain some weight, bring up their protein, all of this before they can even get going with treatment. So it's not just while they're getting treatment, it can be before, during, and even after, just to help with prevent that reoccurrence rate that can be so high with some of these specific cancers. And of course, we provide the latest evidence-based recommendations and standards of practice for cancer treatment and prevention. And I'll tell you now, working in with chemotherapy, I get some off-the-wall questions about herbs and vitamins and supplements, and you got to stay up to par, because I've heard some stuff that I'm like, huh, I've never heard of that before. So you do have to stay on it. And if a patient tells me something and I don't know what it is, I just tell them straight up, I haven't heard of that. Let me do some research and I'll get back to you. Happens a lot. We, of course, perform nutritional assessments on all of our new patients. See if they have had weight loss, how much, and we try to prevent that in the future. Help patients manage eating problems during treatment. Of course, the side effects, we try to minimize them as much as we can. We do use a lot of the oral nutrition supplements. Working with chemo patients, I would say one of my favorite is the Ensure Enlive, because it helps directly with that lean muscle mass, which a lot of these cancer patients, that's what they come in already kind of lacking, is that lean muscle mass. I also use a lot of, I don't know if y'all are familiar with the Kate Farms. It's more of a plant-based. I use it a lot with my pancreatics who've had a Whipple surgery, who have issues digesting milk products, because it is a milk consistency, but it's all plant-based. So it's free of a lot of those allergens. So a lot of my chemo patients with all the GI issues, it's excellent for them. We do a lot with tube feedings. Vidal down in radiation does a lot with her head and neck population, just because all of the swallowing, the chewing is affected from the radiation. So she does a lot. I do a lot more with the GI type cancers. So we're responsible for setting up their tube feeding regimen, educating them, getting them set up with a DME company to get all their supplies delivered to them. So we kind of cover it all. We, like I said before, we do a lot with herbs and vitamins, because patients come in all the time with questions. So you gotta make sure to provide them with evidence-based research. We do a lot of presentations. We actually work hand in hand with social workers. We got some nurse navigators, of course, our doctors, nurses. It's one big team. We work with caregivers, home health agencies, the DME companies. And I do a lot with the post-treatment nutrition recommendations as well. I did this a lot when we had a lot more of the breast cancer. Just educating them on following a plant-based diet, because research shows that specifically with breast cancer, that plant-based diet is what's recommended to help prevent reoccurrence, which we'll get into that kind of stuff a lot more detail later. So this is just, I'm not going to go over all this in detail. What we do pre-treatment, during treatment, and post-treatment, which I'll kind of let y'all look at on your own. It's kind of everything we've talked about, but it's just emphasizing how we follow them through before they even start treatment to when they're at home, done with treatment. We're still calling them, checking on them, making sure they're doing well post-treatment as well. All right, so we do all of our screening and assessments on our patients. Can be conducted at any time. Usually I'll catch them when they're either about to start treatment or starting treatment, and just kind of see nutritionally how they're doing. So our physicians, nurses, navigators, social workers, everybody can screen these patients. If they're having a lot of nutritional issues, Vidal and I are getting consulted. So the assessment is actually conducted by us, the dietitians, which we get all of their anthropometric data, their medical history, labs, changes in weight, and then a food intake history. So this is kind of, let's say a patient's first day of chemo. I've never seen them before. This is kind of the stuff I'll go over with them right off the bat. And then I'll educate them on chemo side effects, what to expect, just to kind of help them kind of get going with everything. All right, so the basic assessment, it is a little bit different for cancer compared to just general population. Your energy requirements, depending on whether they're initially obese, if it's just standard maintenance, or if they're malnourished, that does all play a role in what we recommend. Most of the time, I would say we're doing anywhere from 25 to maybe 35, 40 kcals per kilogram of body weight. Normally, we like them to maintain their weight during treatment. The obese patients is kind of iffy. I may recommend 21 to 25 if they're already obese. I still don't want them losing too much weight while they're undergoing treatment. So I just keep an eye on their weight loss and make sure it's no more than 1 to 2 pounds a week, healthy weight loss. And then our patients who start treatment and they're already cachexic, malnourished, and they need a lot of calories, we'll do 35 to 45 kcals per kilogram of body weight. Protein. Most of our cancer patients will do 1 to 1.5 grams per kilogram of body weight. Now our severely depleted cancer patients, about 1.5. I'm normally go up to, I think the highest I've been up to is 1.8 grams per kilogram of body weight. And it was this little bitty lady, pancreatic. She had a really rough treatment ahead. So I had to make sure her protein stores were up to par and that she could make it through treatment. So it's very individualized. It's kind of the point of saying that. Fluid, normally we just do 1 milliliter per kcal of body weight. Normally, whatever I recommend calorie wise, like 2,000 calories, I match with the water. Try to make sure you're getting in 2,000 cc's of water. And then I don't focus too much on this age base, but these are the numbers that they go by based off of age. But normally we're doing 30 to 40 milliliters per kilogram of body weight. And that's crucial. It also depends. There's certain chemos that can affect the kidneys if you're not drinking enough water. So those sometimes I kind of go a little bit above just to make sure that their kidneys can tolerate the chemo that they're about to get. All right, so your nutritional effects of cancer treatment. We discussed this earlier, I think. Yeah, we went through that one. So the xerostomia is the dry mouth, and you can get this from chemo or radiation. So we say just gotta drink that water, sucking on sugar-free candy to stimulate the saliva, because a lot of our head and necks getting that radiation, their salivary glands are fried. They're not producing as much. So then when that's not there, your mouth's dry, you can't taste as much. Just getting food to break down in your mouth is difficult. We do a lot of educating on adding sauces, gravies, nothing too acidic, nothing too spicy, because of course that can tear the mouth up as well. A lot with broth. We recommend crushed ice or popsicles. And then we recommend actually diluting the milk and supplements with sugar-free club soda or sugar-free ginger ale to kind of help produce that saliva. And then, of course, there's a lot of over-the-counter dry mouth washes, Biotene, ACT makes one. We just got to be careful not to have our patients taking anything with alcohol, like the alcohol mouthwashes, because that'll actually dry them out even more, may cause mouth sores, and it's just a rippling effect from there. So with the mucositis, kind of similar. This is just basically inflammation of the mucosal membrane, so mouth sores. Some of our patients get the thrush, which is that white patchy yeast on their tongue, which can be very painful, can affect taste. And that can just be a common side effect actually from the treatment. You just want to drink a lot of water. Avoid those acidic, spicy foods, anything that's real hard, crunchy. You just got to stick with soft, moist things that'll go right down at that point. And I recommend a lot the room temperature foods and beverages. Anytime the mouth is inflamed, the throat is inflamed, even if it's just severe reflux, let's say radiation to the esophagus, and they just have a lot of that pain, burning, reflux, room temperature is the way to go, because cold things can actually make it a lot worse. Sore mouth or throat, kind of the same. Avoiding those acidic things, spicy things, salty things. No cigarettes, alcohol, or commercial mouthwashes, which we talked about. We do actually recommend puree foods a lot. Our patients look at us like we're crazy, because I actually even recommend baby food sometimes. If a patient's struggling and baby food, they look at me like, huh? I'm like, yeah, it works. And I mean, some of our patients, even it can get so severe on their tongue or the outer parts of their gums that they have to drink through a straw. And we basically, with all of our patients, we just want them eating small meals every 2 to 3 hours, kind of like you're snacking all day long, because it does help get in what they need without overdoing it. All right, difficulty swallowing is common, a lot with the radiation patients. So sometimes the thicker liquids are actually tolerated better when they're having this dysphagia. We recommend adding like gelatin or rice cereal to thin foods just to kind of thicken it up a little bit. And then drink milk with meals actually kind of helps it get down a little bit better. It works better than just water. And I even recommend that a lot with my reflux patients. Milk rather than water with food to help it get down and coat the esophagus or the throat. And then again, puree foods or baby foods. One's favorite. All right, your taste changes. We see that every day. So we usually recommend foods with strong flavors like basil soups, oregano, garlic sauces, mint teas, lemon drops. We recommend that a lot. Helps. Of course, if they're having mouth sores, we wouldn't recommend lemon drops or ginger ale or that kind of stuff, because that would irritate the mouth. But for the most part, I've even had patients tell me pickles. They'll drink a little bit of pickle juice and it helps. If you do this, especially right before you eat, it helps stimulate those taste buds. So they're actually able to eat a little bit better. And we even recommend the salt, baking soda rinse before eating, just to kind of help neutralize the pH in the mouth to help with the taste. Normally your colder foods are better tolerated when you have the taste changes. Because a lot of times with taste changes, you're gonna have smell changes, and anything that's got a strong aroma, if it's cooked, it can cause some more issues. And a random fact that I try with my patients, if they did, let's say soup, they made some soup. I tell them to put a little bowl to the side, put their food in it, put it in the refrigerator for a couple minutes, take it out. When they do that, they go to put it up to their mouth, no smell. So you kind of learn some of these different things to help, but that alone can make a big difference with taste. And they just got to be up to trying new things. They can't come in and say, oh, I hate that, I'm not going to eat that. Well, have you tried it since starting treatment? No. And normally it's their favorite thing going through treatment. So, all right, some of these other side effects that come from chemo, radiation, surgery, whatever it is: diarrhea, constipation. A lot of times you can get both or one or the other. Of course, diet can help, and diet's a big part of it, based on whichever side effect they're having. We actually see potassium levels drop significantly from diarrhea. So I educate a lot on high potassium foods, supplements to help with the potassium, and that kind of stuff. Vice versa, constipation is going to be opposite, of course. prunes, raisins. I've learned that there's this new Smooth Move tea. My patients sometimes use that and it helps wonders. So just depending, this can be a tricky issue because it can literally go from diarrhea to constipation. So you kind of have to stay on them and make sure they know how to take a medication regimen between Imodium and stool softeners, Miralax, that kind of stuff. We work a lot with helping them kind of keep up with that. All right, loss of appetite, very common. Almost every cancer patient I see has this loss of appetite, which of course you don't eat as much. So then when your calorie intake is insufficient to meet the body's energy needs, weight declines. Possible causes, it could be from pain alone from their cancer, anxiety because they just found out they have cancer, they're starting treatment, nerves are bad, fatigue, when you're tired, you don't really feel like eating, depression, and then the type of treatment. The ones that cause a lot of the physical restrictions such as radiation, yeah, that's going to cause decrease in appetite, decrease in intake. All right, we've kind of talked about this, just tips to help improve the appetite. Frequent meals and snacks throughout the day, every 2 hours. I tell some of my patients, set a timer to go off every 2 hours to remind you, okay, I'm not hungry, but I need to eat something. And it does get in their head like, okay, this is what I need to do. So then by habit, they're going to be more likely to follow that later on. Quick grab and go things that don't take a lot of preparation are the best. Supplements are great. Your Boost, your Ensure, all those are very helpful with these patients. Exercising, and we tell our patients, you just got to listen to your body. If you're feeling good, go for a walk. Don't overdo it. We do a lot. I recommend a lot with appetite stimulants. You got your Reglan, Megace, Marinol. Now, of course, they've come out with CBD oil, medical marijuana that they're able to use for cancer patients. So we are kind of utilizing a lot more of that to help with the appetite. All right, so these are the incident of weight loss and cancers of different sites. You'll see right there at the top, pancreas, gastric, esophagus, head and neck. All of those are big vital organs to eating. So of course, those have the most weight loss. All right, cancer cachexia, I just bring it up because it is something people get kind of confused about. So what is cachexia? It's a condition of tumor-induced weight loss, which results in protein calorie malnutrition characterized by involuntary weight loss, tissue wasting, anorexia, poor performance, and possibly death. We have patients that it's not the cancer that kills them, it's the cachexia that can do it. So this is very important. We try to help with this as much as possible. Characteristics of cachexia, you got severe unintended weight loss. They're doing everything. They're like, I'm eating the same amount I ate before I had cancer. Well, it's just because your body is burning so many calories, your metabolism's up, your lean muscle mass isn't there. So all of this kind of can cause that cachexia. You're having a lot of nausea, loss of strength or energy. And I just put this slide because a lot of people are like, what's the difference between starvation and cachexia? They're two totally opposite things. During starvation, your body uses less energy, while cachexia, you're actually constant energy use, burning calories. Starvation, reduced breakdown of protein. Cachexia is increased protein breakdown. With the starvation, you're going to lose fat first, then muscle. Cachexia, you lose your lean body tissue and fat. So just kind of compares. And I just added this because a lot of patients, we see a lot of cachexic patients actually. And those cachexia patients you have are the ones with the esophagus, glottis, your larynx, pancreas, stomach, a lot of those common ones we've kind of already addressed. So what do? There's supplements, appetite stimulants. A lot of these, I actually do recommend the medical marijuana or the CBD oil, depending on what's going on. Oral steroids sometimes alone can help. And you just got to know, being a dietitian, you got to treat the problem. Like, what's causing the poor appetite? Is it side effects from treatment? Is it just no appetite? We got to kind of get to the root of it so that we can help from a food standpoint as well as medication standpoint for that. I'm gonna go through these quick because I know it's already getting. We talked about this, snacking throughout the day, using supplements. We use a lot of different ones. We have the Boost, the Ensure. We got the clear liquid ones for people who have a lot of issues tolerating the milky dairy products, whether it be from diarrhea, nausea, vomiting. And then, of course, we use a lot of the diabetic formulas as well. We do a lot with tube feedings, which we kind of talked about. I'm not going to get into too much detail because I'm sure y'all have addressed feeding tubes, but can either be in your stomach or your intestines. Depending, of course, if the gut's working, you use it. So these are patients who, let's say, radiation's so bad to their neck that they can't physically swallow. Okay, we're going to put a feeding tube in. If their esophagus is restricted from a tumor protruding the entire esophagus, okay, we got to put in a feeding tube. So there's different indications of why we would put a feeding tube, but we do use them a lot. How do we get supplements? We go through insurance, we go through DME companies, cancer services, Miles Perret. There's some patient assistance programs. So, and we do actually get a good bit of donations. So real quick, nutrition after treatment, recommendations, and y'all can kind of look through this stuff on your own too. Recommendations for cancer prevention. You want to be as lean as possible within the normal range of body weight. Be physically active as part of everyday life. Of course, you're brisk walking for 30 minutes. You want to aim for 60 minutes or more of moderate, or 30 minutes or more of vigorous physical activity every day. You want to limit the consumption of energy-dense foods, avoid sugary drinks, fast foods, all that stuff that you would typically recommend avoiding anyways. Eat mostly foods of plant origin, which we kind of talked about. Make sure you're getting at least 5 servings of non-starchy vegetables and fruits daily. You want to limit the refried starchy foods and consume unprocessed grains or legumes and beans with every meal. The red meat's kind of an interesting topic. Limit the intake of red meat and avoid processed meats. And studies have shown that consuming less than 18 ounces of red meat per week is okay. Is anything above that, that's what they're showing, can be dangerous. You want to avoid meats that are preserved by smoking, curing, or salting, or that, of course, have added chemical preservatives. Alcohol, just limit alcohol drinks, moderation. Just the process, we talked about that. And of course, just try to aim to meet nutritional needs through diet alone. Of course, we don't ever say, oh yeah, take this supplement, whether it be like pill form. No, we of course, being dietitians, we want you to take it through food alone. Try to get as much as you can with that. Now, if you have a deficiency, vitamin D, B12, whatever, at that point, we can recommend additional supplements. Just follow the recommendations for diet, healthy weight, and physical activity. I'm not going to really talk about the breastfeeding. All right, so summary: before and during treatment, you want to consume a healthy diet to help maintain weight and meet nutritional needs. Stay hydrated, biggest thing right there. We don't want them getting dehydrated. I've actually, just side note, liquid IV is something I've been using a lot with my chemo patients, which if you're not familiar with it, look it up. It's some good stuff. It goes directly to your bloodstream and it works amazing for hydration. After treatment, it's just eating a plant-based diet, achieve a healthy weight, exercise regularly, and make positive lifestyle changes. And I think that is it.
Any questions? I didn't see any in the chat box. But if they have any, I will definitely shoot you an email so you can answer that. Students, I put in the link, in the chat box, I put the link for you to use so that you can get your bonus points. Fill that out and you will qualify for bonus points towards your final. So Lindsay, I want to thank you so much for taking your time to chat with my students.
Thank you.
It seems like they're starting to log off since we only have a minute left. But,
Yeah.
but I do want to say thank you. So you're free to go, students, if you don't have any questions. We don't have class, no lab this week because Thursdays everyone's out. So I will see you all next week. So Denise told me to tell you thank you for the presentation. She really enjoyed it.
Oh, thank you. Thank you.
Thank you so much. It was really great. I learned so much.
Awesome. Thank you. Thank you.
All right. So they're all logging off. You guys are free to log off. Just use that link so that you can get your bonus points.
All right. Thank you.
I really appreciate it. Tell Adele I said hello.
Okay, I will. Bye.